then unresponsive again. So before looking at the options, we're just thinking naloxone is an opioid reversal. So basically blocks opioid absorption here. Now, the patients need multiple doses because of the very short half-life of naloxone. So remember, the memory trick we use for opioids, remember, it makes the vital signs low and slow with the opioids. So we're talking low respiratory rate, low level of consciousness, as well as low oxygenation, even a low heart rate and low blood pressure. So just remember, naloxone has a big X in there. So it puts an X on the O's in the opioids. So it blocks the opioid effect of making things low and slow. But again, it has a very short half-life. So we have to watch for this low and slow. So the solutions we're looking for are actions to do for this patient. So option number 1 is correct here. Assessing the neurostatus. Guys, remember, naloxone has a very short half-life. It'll wear off very quickly. So monitoring for the low and slow with the opioids, since once it wears off, we'll get more low and slow. Now option 2, also correct. The HCP needs to be aware of this treatment. And option 3, also correct. Oxygen is used to maintain this oxygen status. Because remember, opioids, again, low and slow. We're going to have low and slow respirations. So we have a big risk for oxygenation issues. Now option 4 and 5, also correct. The second dose for option 4 can be given if needed. Usually we give like 3 or 4 doses if the patient's really heavily sedated. And option 5, we do assess respiratory status because naloxone, again, has a very short duration. And option 6 is the only incorrect one here. So the unit supervisor doesn't need to be aware, or basically it just doesn't help the scenario right now. So option 1 through 5 would be the most correct. Okay, that wraps it up. Now using our 3 steps, let's break this down. This question is asking for the most important info regarding the key problem, cancer patient that has been discharged with hydrocodone. So before looking at the options, guys, we're just thinking it's an opioid, we take it as ordered, and it can cause constipation. So the memory trick we're using is opioids makes the vital signs and the GI system low and slow. So how do you know that hydrocodone is an opioid? So guys, just look for the O's. Hydrocodone has a bunch of O's. So we're thinking low and slow vitals, big risk for falling, and orthostatic hypotension from that low and slow blood pressure, and low and slow GI tract. So slow bowel movements, this patient's going to get constipated. So we're thinking fluid and stool softeners. So the solution we're looking for is instructions to provide to prevent the worst potential outcome, or the worst complication from this med. So option number 1, 2, and 3 are incorrect here. Now option 1, technically the blood pressure and vital signs should be assessed before giving this medication, but there's nothing in this option that really alerts us to a priority here. And option number 2, antiemetics are best for nausea with any type of opioids, but it's not the most priority. And option 3 is also incorrect. The medication can cause itchiness from histamine release from use of an antihistamine instead. But really, option number 4 is our best option because opioids make things low and slow, like constipation in the GI. So this medication can cause constipation. So option 4 is our best option here. Okay, that wraps it up. Now, using our 3 steps, let's break this down. This question is asking for priority actions of what to do now for the key problem, hydromorphone, hypoxic, and this patient just got naloxone. So the memory trick we use is opioids make the vital signs low and slow. We're talking low respiratory rate, low LOC, or this level of conscious that is low, and low oxygen, as well as like low heart rate and blood pressure. Now, naloxone puts the X's on the O's in opioids, blocking opioids. So hydromorphone has a bunch of O's, so that's how we know it's an opioid. But guys, here's the deal. Naloxone has a very short half-life, so it's gone quickly. So guys, we have to give multiple doses for a patient. So we always monitor for the low and slow when we give naloxone because it wears off really quickly. So the solution we're looking for is what kills this patient first. So option number 1 and 2 are incorrect. So alprazolam is a benzo, which basically makes everything low and slow as well. So it decreases the respiratory rate. It won't increase it. Now, option 2, also incorrect. Documenting and leaving does nothing for the patient right now. It's like the worst thing you can do. And option 3 is correct here. So closely monitoring the respiratory status prevents the worst possible outcome of respiratory depression. And option 4, 5, and 6 are all incorrect. So number 4, you may need to change, but it doesn't help the patient right now. And option 5, pulse ox doesn't give CRP. Technically, option 6 is just like option number 1. Alprazolam, so PAM and LAM ending drugs, are these benzos, which makes everything low and slow. So we're talking decreased respiratory rate. Okay, that wraps it up. Now, using our 3 steps, let's break this down. This question is asking for appropriate interventions for the key problem, IV morphine, that's PRN. So before looking at the options, we're thinking we give it as needed because it's PRN. We assess the pain before giving any pain medication. And we assess the vital signs because the memory trick for opioids, it makes the vital signs low and slow. So the memory trick here is to look for the O's for opioids. So hydromorphine, or even morphine here, I was meant to say hydromorphone, and morphine have big O's in it. So it makes everything low and slow. We're talking vital signs and even the GI tract, leading to constipation. So the solution we're looking for are actions to do for this patient. So option number 1 is correct. Giving the meds and assessing for pain. So it's a pain medication. We always do an assessment before we give anything, but a pain assessment is always key. Now, option number 2 is incorrect here. Morphine should be given PRN or as needed. Now, option 3 is correct. So stool softeners PRN because morphine makes everything low and slow, leading to constipation. And then option 4 and 5 are both incorrect here. So we reassess after we give any medication, especially morphine administration. And option 5, stool softener are used daily and not weekly. So again, just think opioids make the bowels low and slow. So these patients need stool softeners. Again, daily and not weekly. Okay. Now, using our 3 steps, let's break this down. This question is asking for priority actions of what to do right now for the key problem, IV hydromorphone and dizziness when standing. So the memory trick we use is opioids make the vital signs low and slow. So we're talking slow position changes. So how do you know hydromorphone is an opioid? Well, guys, look for the O's. So hydromorphone. So remember, low and slow vital signs. So low blood pressure, low heart rate, and low level of consciousness. So orthostatic hypotension is is a blood pressure lowering, so we always change positions very slowly for safety. So the solution we're looking for are interventions to do right now to maintain safety for this patient. So option number 1 is incorrect. There's no walking when the patient's dizzy for a huge risk for falls, and the NCLEX is all about safety, so no fall risk here. Now option 2 is correct here. We always sit the patient down if they're feeling dizzy to prevent a fall. And option 3 and 4 are incorrect. Blood pressure reading in 2 hours does nothing for the patient right now. And option 4, strict bed rest is not needed, just these slow position changes. And speaking of, option 5 is correct. So dangling the feet first will allow for blood flow redistribution and really stable out the blood pressure to prevent orthostatic hypotension. So fancy words for slow position changes. And option 6 is incorrect. We always place a fall risk right now to prevent the worst possible outcome. So placing it at the end of the shift does nothing for the patient right now. So option 6 is incorrect. Now using our 3 steps, let's break this down. This question is asking for the greatest risk patient for the key problem, respiratory complication. So we're thinking the greatest risk. So before looking at the options, we're thinking history of respiratory disease like asthma or COPD. And the second thing that I'm thinking is elderly or advanced age, because the respiratory tract is usually worn and torn by then. So the solution we're looking for are patients that are most likely to have a respiratory problem. So we're looking for the oldest patient with a respiratory disease. So option number 1, 2, and 3 are all incorrect. So just let the age help you here. So 20-year-old with allergies or allergic asthma, Loratab, not really the greatest risk. Now if option 1 gave me an asthma attack, that would be deadly, but it's really not the greatest risk. Now option 2, a 29-year-old abusing Percocets, we're thinking bronchitis and allergies, but guys, really not the greatest risk here. And option 3, a 49-year-old with sleep apnea, that's 5 days post chest removal. That was a really good distractor, but not the greatest risk over option number 4, which is the most correct here. An 80-year-old with advanced age here has COPD and emphysema and multiple pain meds. Guys, those pain meds is what really tip the scales. So remember, the pain meds like opioids make things low and slow, just adding to the low respirations. And this patient has advanced age and a respiratory disease, so they're most at risk. So option 4 is our most correct. Okay, that wraps it up. Now using our 3 steps, let's break this down. This question is asking for priority concerns for meds regarding the key problem, a patient with hypertension. So before looking at the options, we're just thinking sodium swells the body and can make the high blood pressure even worse. And then I'm just thinking ABCs here. So the solution we're looking for are meds that have the highest risk for the worst possible outcome. So basically, something that's going to increase this hypertension. So option number 1 is incorrect. Daily stool softeners is okay and normal. And option 2 also incorrect. Eye-ending diuretics makes the body dry, and it's really good for edema. So this patient has hypertension, so it's going to make the hypertension better. Now option 3 is correct here. Naproxen is our NSAID, which is not good for the entire body. Now, it can increase the blood pressure and increase the bleeding. So big NCLEX tip here. NSAIDs are not good for the entire body, and typically it's the wrong thing for the majority of the NCLEX questions. Now, there are very few times that we can give NSAIDs, and it's okay on the NCLEX. Now, option 4 and 5 are both incorrect here. Daily PPIs for heartburn, that's okay. And option 5, acetaminophen for arthritic pain, that's okay too. So So it's actually preferred to give acetaminophen over NSAIDs in most cases when the liver is not involved. Okay, that wraps it up. For more details, now using our 3 steps, let's break this down. This question is asking for adverse effects regarding the key problem, aspirin. So before looking at the options, we're thinking aspirin is an antiplatelet, so we have easy bleeding and a big risk for toxicity here. So the solution we're looking for are adverse effects, or things that are not side effects or not normal, but adverse effects, something that can harm the patient here. So option number 1 is correct here. So the key word is dark stools that can indicate bleeding. So indicate bleeding in the GI. So guys, melena is basically blood inside the stool. If you guys didn't know that, just use the keyword dark stools. Stool should not be dark. That's a big blood in the GI tract. So just remember that. Option number 2 is incorrect because decreased heart rate is not an adverse effect of aspirin. It really has nothing to do with the heart, mostly for the bleeding. Now option 3 is correct. Bruising can indicate bleeding from this antiplatelets, or basically decreased clotting. Now option 4 is incorrect here because increased blood pressure is not an effect of aspirin, but option 5 is correct. Tinnitus can indicate toxicity, basically ringing of the ears. So just remember, tinnitus can be toxic. So toxic kidneys and toxic ears, ringing of the ears here. Okay, that wraps it up. Now using our 3 steps, let's break this down. This question is asking for priority interventions of what to do now for the key problem, pain with a PCA pump. So this persistent pain. So whenever you guys hear that pain is persisting, we always just think assessment of the pain and adjunctive treatments that don't require a new order. Or we're just going to readjust this med order, but usually that's like the last line before calling the HCP. So the solution we're looking for is the best option to do right now for this pain. Option number 1 is incorrect. Technically, we need an order before we give more pain medication. So option 1, incorrect. Now option 2 is always correct here, guys. We always do an assessment. For increased pain, we increase the assessments. So always we evaluate PQRST or OPQRST for any type of pain. Now option 3 and 4 are both incorrect here. You may need more of the med, but guys, it's not priority right now. And option 4, reviewing the PCA pump doesn't really help the patient's problem right now. Now option number 5 is correct. Non-pharmacological techniques like an ice pack or even distractions, guys, because it doesn't require a medication order from the HCP, which can delay pain treatment. Now option 5 is incorrect. We want to do a pain evaluation right now. Okay, that wraps it up.